You know what plastic surgery is all about? It's about giving back, okay? It's mastering your craft and then teaching the next generation to be the best they can be. That's what I do day in and day out. And you'll see in this amazing journal club that we had where we're teaching our residents and fellows all about the hottest, latest things. And this happens to be the Journal of Plastic and Reconstructive Surgery. Of course, I'm a little biased since I'm the editor-in-chief of this journal, but it's also about other things. Here's a recent book that's a bestseller on facial danger zones. It's all about how to stay safe with surgery, fillers, and all the new non-invasive devices. So, learn to be a good doctor, give back, teach others. That'll take you to a higher level. Good morning. People always ask me, what's my routine day? My routine day is I'm up at 5:30, exercise, read the morning news, update on the journal, prepare myself for the day, update my 3 goals for the day, which I must accomplish so that I can feel like I have done all the things that I need to do, and then go to work and be your best, live your best, and always, always give back. You know, that's a different operation, but yeah, I'll release it. I'll just go in actually below the orbicularis, and I'll just release the superficial portion of the deep retinacular ligament. There's a superficial and deep portion, so it's safe. If you just put your scissors through that the superficial part, after you put your suture in, you're going to get incredible motion. Then that negative vector. Those patients always have a negative vector orbit, so then I augment them and make them neutral. But be careful. It's a great article. It's dated, but
yeah, no, it's one of those good articles to read, though, because like you said, it's like all this stuff that he's trying to address at the time and getting slack for.
Oh,
but then,
I mean,
somebody my age grows up, and I haven't 99% of everybody I've ever scrubbed with does a somewhat similar version to this.
So it's purely off anatomic landmarks in a unilateral case. He mentioned several times that oftentimes what you may perceive as unilateral is actually just an asymmetric bilateral ptosis, so be looking for that, because if it's bilateral and you only correct one side, the other side is going to be worse post-correction.
Just a caveat on that is it is rare for me or anybody to do a unilateral ptosis repair. You got to be very careful because you'll be compensating for that, and if you get within 1 millimeter of that, that's fine. Your eye will equilibrate in about a month.
So I noticed in primaries in Cleveland, Dr. Gyron pretty much always did the modified Putterman, like the Fosnell Servat, so the transconjunctival excision with the clamp. How easy is it to overshoot that? You're saying it.
You know what? It's actually, I've only done a few, but it's pretty hard to overshoot it.
Okay.
I don't know why, and Putterman is a smart guy. He's from Chicago, and I must say it's brilliant. You have to use his clamp.
There is a special clamp. Yes.
We have the Putterman clamp, but you basically go in and you just clamp it, and you put out 5 or 7 millimeters, and you cut it off, cauterize it, and you just put in running fast 6/0.
Does that clamp have a hole to put the suture in?
Yeah. No. You just run it. It's pretty. Yeah, it's very easy.
The real thing is the trend towards non-surgical rejuvenation. This has increased by over 700% in the last several years, and this includes use of filler, Botox, and fat grafting. And I think that's the key is utilizing these non-surgical methods, raising a brow when it really does have to be raised, and then just personalizing the approach and technique to the actual patient's finding. And there's not a perfect way to do so.
And there's that temporal brow. There's a lot of different ways of doing it. Now, you know that I guess at NYU they do subcutaneous lifts, right? Doesn't Charlie Thorne? A subcutaneous lift?
The subcutaneous temporal.
Temporal.
Yeah.
And didn't you write an article?
I wrote an article.
And how did they look? Okay.
From what he showed me.
Yeah.
Who knows?
And there's so subcutaneous.
Yeah, just subcutaneous. Just hairline and then subcutaneous.
It's easy.
Yeah, it's easy and it's safe.
Yeah, it's safe because you're above them and also above them, the frontalis.
I've done that a lot. If you just take your facelift incision and you just extend it a little bit, you get some brow elevation there. I mean, but
I just use fat now. I mean, I unless if they really are adamant, and I tell them about alopecia and all those things, because if you get alopecia, you know it's going to be a 3 to 6 month deal. I mean, they just need to know that if they get it. I mean, it happens, but even if you don't touch the galeal, if you don't touch the scalp, and you're just doing deep galeal sutures, you can still get alopecia. The hair is not, and I don't cauterize the scalp. I don't cauterize the scalp. You can still get alopecia. So that's why, and I don't like that look. I don't like that look at all. And I can tell you, patients don't want it. I mean, it's probably 1 in 20 facelifts that says, I need my brow up.
He was older, and because of his hairline, I didn't know if there
No,
was a good
100%.
option apart from that. His brows sat below his supraoral rims, and his vision improved with manual elevation of his brows. And after elevating the brows, he still had excess skin, so we did upper lid blepharoplasty, did a lower lid blepharoplasty with a skin muscle flap and fat redraping, and a canthopexy bilaterally.
That's what
I
saved.
don't have,
That's what saved you, I think.
I'm sorry?
That's what saved
The
you.
canthopexy, yes.
Did you do a temporary
Definitely
lateral
did.
torsorrhaphy or something?
I did not.
That's good.
But he probably could have benefited from that.
But did he have a lot of eyelid dryness afterwards?
He did not complain of that.
Did you ask him?
He was on a very strict regimen of lacrolube and drops, and didn't have significant chemosis. Thankfully, has not developed ectropion. There's like a 10 to 12% risk of developing ectropion with this method, but it's the only one that I've,
How'd you do your direct brow lift?
superciliary.
Did you bevel parallel to the eyebrows?
I'm sorry?
How'd you do
To the
it?
hair, yeah. And then here's a lateral view. Here's side by side.
Her main complaint out of everything was really that upper right eyelid, central and lateral skin excess was her biggest complaint. But we did.
Did you address
actually
the eyelid ptosis?
We addressed everything. I did not address the ptosis because she has baseline significant lag ophthalmos, so it's tonic and static pictures, but she's actually not able to fully close.
She's got lag because of
Right. Basically, it's a neurogenic slash.
So what's her eyelid excursion when she closes?
When she fully closes, it's she has about 6 millimeters.
That's her excursion. Levator.
Wait, on the right?
On the right side.
On the left side?
And it was relatively selective. It was 6 and 4.
So what does that tell you that you couldn't do?
The unilateral correction.
Well, if she has 6 millimeter eyelid excursion, she can't do a levator or anything else. So what you've seen is really a typical example of what I do every day in a Socratic method. I'm teaching others, teaching my colleagues, fellows, residents, all about the art and finesse of plastic surgery and beyond. And it's also about life as a physician, life as a human being. You want to live each day to your greatest level, because there's several things you'll never get back. It's time is the most important thing. And one of the things that you treasure more and more as you get a little older is time, okay? So cherish every moment. Hang out with people you like. Give back. Love what you do.